The following podcast is part of a certified educational activity titled Great Expectations, Helping Patients with Spinal Muscular Atrophy and Their Families Understand Diagnosis and Treatment in a New Era of Therapy. Access the entire activity and complete the post-test at peerview.com/HWV860. Downloadable slides and practice aids are also available.
Hello, I'm Dr. Diana Castro from the University of Texas Southwestern Medical Center in Dallas, Texas. Welcome to this case-based activity on great expectations in a new era of spinal muscular atrophy treatment. As part of this activity, we will review the genetics, epidemiology, and course of SMA, examine new disease-modifying therapies for the treatment of SMA, including important features and key evidence regarding efficacy and safety, and explore how new disease-modifying therapies are changing the landscape of SMA management. What do I need to know to help my patients who have spinal muscular atrophy or SMA? Spinal muscular atrophy is a degenerative disease, autosomal recessive disorder, who has a prevalence of 1 in 6,000 to 1 in 11,000 live births in the United States. It has a carrier frequency of 1 in 40 to 1 in 60. SMA is caused by the lack of a protein called SMN, or survival motor neuron. This protein is very important for the anterior horn cell to develop. The anterior horn cell will help develop the nerve and further down the muscle and the neuromuscular junction. Whenever there is lack of this protein, the patients will develop muscle weakness in the case of patients with spinal muscular atrophy. The body has two SMN genes, SMN1 and SMN2. SMN1 produces 100% of this protein that is needed. SMN2 only produces 10% of that protein. Patients with spinal muscular atrophy do not have SMN1 due to a homozygous deletion in 95% of the cases or point mutations in 5% of the cases. So these patients will only rely on the SMN2 gene that they have left in their body. So the number of copies of this SMN2 will give you a little idea about prognosis, because if more SMN protein is made, the patient will be stronger. This graphic represents the neuromuscular milestones and trajectories from birth to adult life in SMA types treated with supportive measures. You have a normal patient, the green line, and then the other line would represent patients with SMA. The dotted line is a type 1. Patients with type 1 are born completely normal looking. They are normal babies, beautiful babies that don't show any symptom. So this is what we call the presymptomatic phase. Unfortunately, when they get around 3 months of age, they will have an acute phase of deterioration with problems with their motor function, difficulties feeding, and difficulties breathing. The second line is the type 2. Those are the red line. These patients are born, again, completely normal. They have this presymptomatic phase that is longer, and when the time comes for them to stand up and walk, they are not able to. These patients are only able to sit without support. They may stand up, but they can never stand up and walk independently. Type 3 are patients that have a longer presymptomatic period. They are diagnosed later in life at around 5-6 years of age when they start having falls, difficulties with ambulation, and they get diagnosed later in life. Their expectation of life is completely normal. They may lose ambulation when they get older. And you have type 4, that is the purple line, patients that are diagnosed in their 20s or 30s with completely normal life expectation. The SMA therapeutics landscape is changing due to 1, newborn screening, and 2, the medications that are available. Newborn screening are helping us overcome the delays in the diagnosis of spinal muscular atrophy. SMA newborn screening was added through the RUSP in July of 2018. Each state must decide whether they include SMA in the required screening or not. Many states rely on the recommendations, and right now at least 23 states have implemented the universal newborn screening for SMA. Now let's look at the FDA-approved and emerging therapies for SMA. There are 2 medications that are approved. One is nusinersen, and the second one onasemnogene. Nusinersen is a SMN2-directed antisense oligonucleotide that is given as an intrathecal injection with 4 loading doses and then maintenance dose every 4 months. The indication is broad. It's treatment for SMA in pediatric and adult patients. Onasemnogene, on the other hand, is an adenovirus vector-based gene therapy. It's a one-time injection over 60 minutes. The indication right now is patients less than 2 years of age with SMA and mutations in both alleles of the SMN1 gene. As we say, the therapies and the newborn screening has been changing the scenario and the landscape of SMA. We see in the past, before approval of therapies, we had less patients that were presymptomatic and more patients that were diagnosed later on in life. Now with newborn screening and therapies, we're going to have a larger number of presymptomatic patients diagnosed and hopefully treated early, and less patients diagnosed later on in life. In the remaining program segments, you will have the opportunity to select case scenarios by choosing patient characteristics. That will lead you on an exploration of SMA management in the era of disease-modifying therapies. You have chosen the case of William, a 3-month-old baby who presents with symptoms consistent with SMA. William was born full-term, pregnancy and delivery were normal. He did not have a newborn screening for SMA. The parents thought he was having a normal development until he was around 3 months old, where he seemed he did not have the same activity as other children. He was happy and alert. His pediatrician noted that he was not able to lift his head when on his stomach and that he lacked muscle tone. William was referred to a neurologist who confirmed the diagnosis of spinal muscular atrophy type 1. He had 2 copies of SMN2. William's parents and doctors need to decide on how to proceed. This is a typical presentation for a patient with spinal muscular atrophy type 1. Babies that are less than 6 months of age who do not reach any motor milestone. Their life expectancy is less than 2 years of age without treatment. They present with severe hypotonia, unable to sit or roll, and the number of SMN2 copies is usually 2. In this diagnostic testing algorithm, we will go through the case 1 when the clinical is suspicious for SMA is present, or 2, you have a newborn screening that is positive. In both cases, there is a confirmatory testing looking for the deletion or mutation in the SMN1 gene. If there are 0 copies, that confirm the case. If there is only 1 copy of SMN1, sequencing is required looking for mutations. If there are more than 2 copies, most likely this patient does not have SMA. Then on the other hand, the copy number of SMN2 will predict the severity of the disease in many cases, and will also allow us to decide in terms of therapy. If the patient has only 1 copy, it's probably a type 0. The treatment will be based on symptoms because these babies are born with extreme difficulties feeding and breathing. If the patient has 2 copies, it's likely going to be a SMA type 1. If the patient has 3 copies, could be probably a type 2 or a type 3. And if the patient has 4 copies, could be a type 3 and 4. In the case of SMA type 1, 2, 3, and 4, there is no question, but the patient should receive treatment. Now let's have an overview of the assessment and intervention for these patients. These are nutritional recommendations for all the patients with spinal muscular atrophy. Swallowing and feeding difficulties are important to evaluate. Very early, we can ask for choking and coughing episodes or perform swallowing tests. Feeding tubes are maybe necessary in some patients to supplement nutrition. The appropriate caloric intake and weight control is also a very important point. We don't want to have patients that are undernourished or overweight or obese. And it's also important to have very close monitor of the fasting times during acute care episodes. If the patient is going to have a surgery or the patient needs to be MPO for some reason, it's important to limit this because their reserves or muscles are very low. Monitor and treat gastrointestinal dysfunction. It's also an important point. We can treat reflux, constipation. We can also treat delayed gastric emptying and vomiting. Respiratory recommendations. In this case, we will center this to non-seizures or SMA type 1 in the case of William. What is the goal? The goal is to have a proactive approach. We want to have patients evaluated very early with physical examination. We can look at the shape of the chest. We can look at the cuff. We can also measure other things like the CO2 or perform sleep studies. Gastroesophageal reflux is important in this case because of the risk of aspiration. What can we do in terms of intervention? Airway clearance is the most important, with oral suctioning or with therapy with manual chest therapy or cough assist in some cases. The second point is ventilation. We have to use a bilevel non-invasive ventilation. We do not recommend the use of CPAPs, but only BiPAPs. And medications that can be used in some cases are medications that are targeting reactive airway disease, like nebulizer bronchodilators. These patients are seen every 3 months, then every 6 months. The rehabilitation recommendations, again, talking about non-seaters like William, it's optimizing function and positional tolerance and minimizing impairment. The assessments are the posture, the degree of scoliosis, hip dislocation, sitting tolerance, the chest deformities, and contractures that are very frequently seen. The interventions, positioning, bracing, stretching, extremely important. Every day, these patients need to be stretched, not only by the physical therapists, but their families, and promote function and mobility with mobility systems or adapted equipment. Currently approved disease-modifying therapies are 2 of them. One of them, nusinersen, and the second one, onasemnogene. In this case, both of them will be approved for this patient because he is only 3 months of age. Here's the clinical evidence to support their use. Nusinersen was studied in a phase 3 study called ENDEAR, where 121 patients with SMA type 1 and 2 copies of SMN2 were randomized to nusinersen or to sham injection. 80 patients received nusinersen and 41 were in the sham group. The primary endpoints were motor milestones response, defined as Hammersmith Infant Neurologic Examination, or HINE, the event-free survival, time to death, or the use of permanent ventilation, defined as more than 16 hours of ventilation a day for more than 21 days. Here we see the clear response the patients that were on the nusinersen treatment had. In terms of motor milestones, 51% of those patients had a response compared to 0% in the sham control. We're talking about milestones like holding their head, rolling over, sitting. Event-free survival, combining respiration and survival, 61% in the nusinersen group and 32% in the sham. And survival only in terms of death, 84% survive in the nusinersen group and 61% in the sham group. And the CHOP intent is another scale that we use to evaluate muscle function, not motor milestones. And in this case, the patients that received nusinersen had a 71% response compared to 3% in the sham group. The second medication we're talking about is onasemnogene. Onasemnogene was trial in a phase 1 study called STAR in 15 patients. All of these patients had a disease onset prior to 6 months of age, and they also were SMA type 1. These patients also had 2 copies of SMN2. Patients were divided in 2 cohorts. 3 of those patients were in cohort 1 with a low dose, and 12 patients in a cohort 2 with a higher dose. The outcomes were safety and time until death or need for permanent ventilation. Here we see the results for the cohort 2. Event-free survival was 100% in cohort 2. Control of the head was 92%, rollover 75%, seats and assisted 92%, and non-nutritional support 50%. These compared to historical controls where you see patients are only 8% event-free survival up to 2 years, and then there is no achievement of any motor milestones for the patient in the historical cohort. Having the knowledge and being updated with the therapies that are available these days will allow us to have the discussions with the families. There are larger neuromuscular institutions where the patients can be referred, and we can have discussion in terms of the interventions that are preferred. Dosing, frequency, the administration route, the use of gene therapy versus the antisense oligonucleotide. It's important to have these discussions before making any treatment decision. You have chosen the case of Maria, a 15-month-old girl who presented with symptoms consistent with spinal muscular atrophy. Maria had a remarkable well-child visit through 1 year, and is now due for her 15-month visit. Maria was screened for SMA at birth with a negative result. SMA deletion was not identified. At 15 months of age, she can sit unsupported, she can stand with support, but seems to be getting more unsteady. The parents noticed that she has developed also a hand tremor. Based on her clinical presentation, gene sequencing was performed, confirming the diagnosis of spinal muscular atrophy type 2. She was identified with 3 copies of SMN2. Maria's doctors and parents are working to come up with a treatment plan that they think will be best for her. Maria also has a newborn brother who is less than 1 month of age. This is a typical case for a patient with spinal muscular atrophy type 2. The age of onset is between 6 to 18 months. Patients are able to sit. Some of them may stand up with support, but never without support, and they can reach the ability to walk. Life expectancy is between 10 to 40 years of age, and they present with proximal weakness, with inability to walk independently, like I said, and unsteadiness. The predictive SMN2 copy number is usually 3. In this case, both nusinersen and onasemnor gene are approved for this patient, and I will show you the evidence that support the benefit of disease-modifying therapy for individuals with later onset spinal muscular atrophy. In the case of nusinersen, their benefit was demonstrated through a study called EMBRACE. This was for patients between 6 months to 2 years of age. In this case, the study was randomized with patients receiving nusinersen or sham. 79% of the patients that received nusinersen versus 29% of the ones in SHINE were able to reach milestones in the Hammersmith scale. Also, the safety and tolerability was similar to all prior trials. Rehabilitation recommendations in sitters. The goals are to prevent contracture, scoliosis, and to promote function and mobility. The assessment we perform are guided through looking to posture, the foot and chest deformity, scoliosis, hip dislocation, contractures, the level of muscle weakness, and this all is done with functional scales. The intervention are targeting positioning. Positioning can modify through bracing, stretching, not only manual stretching, but with other equipments like orthotics. Promote function and mobility through mobility system or devices based on the individual ability. The spine deformity management depends the state of the patient. In this case, this patient is a sitter, so patients will require orthotics that will help with the spine position, but then later on in time, they likely will have to get through surgery to get growth-friendly rods. Nutritional and respiratory recommendations are essentially the same for non-sitters, and assessments should be performed routinely. We usually see patients with spinal muscular atrophy around every 6 months. In the case of Maria, it's important to think about 2 main points. One, the genetic testing for asymptomatic children should only be considered in the result if the result will modify the management. This because she has a brother who is less than 1 month of age, who, if he is diagnosed, he could be treated very early. And 2, the other point important is the genetic testing of the parents of a child with spinal muscular atrophy. It's important to confirm the carrier status because this will facilitate the genetic counseling and provide information for family planning. You have chosen the case of Hansen, a 6-year-old who presents with symptoms consistent with spinal muscular atrophy. Hansen has had no usual health concerns until recently. He has an 8-year-old brother and a 3-year-old brother, healthy. Hansen's parents took him to his pediatricians because in the past month they noticed that his gait has changed and he seems to be falling often. Hansen was diagnosed with spinal muscular atrophy type 3. He has more than 3 copies of SMN2. This is a typical case of spinal muscular atrophy type 3. Patients with SMA type 3 present older than 18 months of age, but they usually don't get diagnosed until they are 5 or 6 years of age. Patients are able to walk independently. Their life expectancy is normal. They can walk and reach completely normal milestones, but very often they may lose the ability to walk over time. The predicted number of SMN2 copies is between 3 to 4. Disease-modifying therapy in ambulatory patients with spinal muscular atrophy is limited to nusinersen. The indication is for pediatric and adult patients. Disease-modifying therapy improves walking distance and fatigue in ambulatory patients. This has been demonstrated by some of the nusinersen studies. In one of them, in ambulatory patients with a number of 14 patients with type 2 or 3 between 2 to 15 years of age, the 6-minute walk for the patients with type 3 show an increase of 98 meters and a fatigue change of around 3.8%. If we go back about rehabilitation recommendation, in ambulant patients, it's going to be all about promoting function, mobility, joint range, balance, and endurance. The assessment can be with functional scales that will look at mobility, the time test, endurance, and muscle weakness. We also should be looking at the contractures, posture, scoliosis, and hip dislocation is less common. The interventions are directed to promote function and mobility through aerobic and general conditioning exercise that it should be monitored by therapists, stretching, that it's not only daily stretching at home but also with orthotics, and position and bracing through lower limb thoracic braces sometimes, and scoliosis surgery that is more rare in patients that are able to walk. If we think about Hansen, one of the most important things are related to what type of accommodation Hansen will need at school. The MDA recommends the following aids, interventions, and supports: physical therapy, adapted physical education, occupational therapy, assistive technology evaluation, and school accommodations, like an extra set of textbooks, elevator, class schedule to limit fatigue, and adapted emergency evacuation plan. You have chose the case of Joy, a 3-month-old baby diagnosed with spinal muscular atrophy and treated with a disease-modifying therapy, or DMT. Joy was diagnosed with spinal muscular atrophy type 1 at 11 weeks of age, having 2 copies of SMN2. She was treated with a single dose of onasemnogene, and since the treatment, her motor skills have improved in several areas, including her motor function and motor milestones. The first one, patient had spontaneous upper and lower extremity movement, knee extension, head control, elbow flexion. She's not having difficulties with breathing, and she can hold her head up, but she does not try to push up when lying on her tummy. Early intervention yields better outcomes. We can see this in the study ENDEAR with treatment with nusinersen. Patients that were treated earlier were able to reach higher motor milestones faster than the patients that were treated but were treated later. Earlier treatment was also demonstrated in patients that were treated in the START trial with onasemnogene. Here in this graphic, we have the orange are the patients that were treated earlier in the condition compared to the ones in gray that were treated but were treated later. So the number of motor skills and motor milestones was reached faster in these patients that were treated earlier. So how do assessment and intervention change in the context of DMT? Monitoring assessment is still necessary for patients that receive therapy. Interventions may also be necessary. It's very important to make the patients understand that these treatments are not a cure. Patients should be coming to the clinic to receive a standard of care because it's important to take care of all our areas, respiratory, digestive system, and so on. As the landscape in SMA is changing, the resources for these patients are going to be different. The needs are going to be different. So the patients should be able, and the caregivers should be able to be directed to different resources like Cure SMA, the MDA or Muscular Dystrophy Association, National Organization for Rare Disorders, Orphan Disease Network, or the Rare Disease Clinical Research Network, where the families can find different resources in terms of equipment, in terms of access to different clinics, and access to therapies. You have chosen the case of Joseph, a 15-month-old boy diagnosed with spinal muscular atrophy and treated with a disease-modifying therapy. Joseph was diagnosed with spinal muscular atrophy type 2 via newborn screening. most likely type 2 because the patient had 3 copies of SMN2. He was treated with nusinersen for 13 months, starting when he was 2 months old, and he has not brothers or sisters affected with the same condition. To know about Joseph's status, his CHOP intent score at his last doctor visit 3 months ago was more than 60, with the highest score being 64. He's having no difficulties with breathing or feeding. He's not yet walking, but he's standing with support and has met other motor milestones. His last treatment was delayed due to the COVID-19 pandemic. Early milestones are achieved in children who receive presymptomatic disease-modifying therapy. We can show these with at least 2 studies. The Nurture study was performed in 25 infants aged less than 6 weeks with presymptomatic genetic confirmed spinal muscular atrophy. 15 of them had 2 copies of SMN2 and 10 had 3 copies of SMN2. At the last visit, children were around 34 months of age and past the expected age of symptom onset for spinal muscular atrophy type 1 or 2. All were alive and none required tracheostomy or permanent ventilation. The adverse events in this study were minimal, 8 possible related to studied drug, 7 of them resolved, 1 case of proteinuria, and clonus was not resolved by the cutoff date. No serious adverse events were reported, and the lumbar puncture was generally well tolerated. The Heine motor milestones, where we see that 100% of the patient achieved head control. Sitting without support was also achieved in 100% of the patient. 23 out of the 25 are walking with assistance, and 22 are walking alone. You can see that patients that were both in the group of the 2 copies and the 3 copies have been able to achieve these motor milestones. Another important way to look at these results is looking at the CHOP intent. This is a motor functional testing that will tell about specific areas in the motor function. As you see, the patients in the green line are the patients that had 3 copies, and the patients in the blue line had 2 copies. Both of these groups reach very high scores. The max score is 64. Are we seeing that the patients with 2 copies reach around 62 points, and the patients with 3 copies reach almost 64, the max score. But it's also important to see the gray line under, where you see the natural history of patients with 2 copies of SMN2, where they will never reach this number. They will start with around 20, but progressively will lose those points with time. In the case of onasemnogene, these results were demonstrated through a SPRINT, a phase 3 study. These results are from December 31st of 2019. Patients were also treated in the presymptomatic phase. They were less than 6 weeks of age. There were 14 of them with 2 copies and 15 of them with 3 copies. Patients were treated as a 1-hour infusion, and then they had an outpatient follow-up through 18 to 24 months of age. The results of SPRINT show us that all patients are alive and free of ventilatory support. They don't need feeding support, and the adverse events related to treatment were present in 17 patients, but there were not serious adverse events. The most common adverse events or side effects were pyrexia in 30% of the patients, upper respiratory tract infection in 23%, constipation 17%, and nasopharyngitis in 17%. If we look at the results for the primary and secondary and exploratory points, we see that the patients with 2 copies of SMN2 in the Baileys, 8 out of 14 were able to sit independently, 4 out of 14 were able to walk independently, and if we think about the CHOP intent, again, with a max score of 64, this patient reached more than 50 or 58 points. In the case of the patients with 3 copies of SMN2, we have 4 patients out of the 15 that can stand independently and 3 out of 15 that walk independently. So how does rehabilitation care change for seizures on patients that have been treated? Now, we're talking not only about seizures, we're talking about ambulant patients. So we have to promote function, mobility, joint range, balance, and endurance. In this case, the patients may still develop contractures. They may still develop tightness. So one of the interventions that is very important is stretching. Patients should be having a plan for stretching at home, and also orthotics may be needed. Position and bracing is important, mainly for the patients that are sitters. The patients that can walk are usually not developing scoliosis. But promote functionality and mobility is also important for the ambulant patients. Problem with them is that usually they cannot walk at the same speed as others. They cannot perform exercise as others. So it's important to keep their weight through aerobic and general conditioning exercises. Going back to Joseph and the COVID-19 pandemic, it is important to remember that patients with spinal muscular atrophy may be at a higher risk than other populations. Patients and families should follow the recommendations given for patients with serious illness. SMA treatments, planned or not emergent, should not be perceived as elective or not urgent, meaning the treatment should still be given, but there are some other things that can be more relaxed in terms of functional testing performed in clinic or clinic visits. You have chosen Sandra's case. This is a 6-year-old girl diagnosed with spinal muscular atrophy and treated with disease-modifying therapy. Because Sandra's older sister, a 10-year-old, was diagnosed with spinal muscular atrophy type 3 with 3 copies of SMN2 when she was 2 years old, Sandra's parents had her tested as a newborn. She has 4 copies of SMN2 and is likely to develop SMA type 3. Sandra's symptoms onset began when she was 2 to 3 years of age. She had been walking independently, but she seemed to be having more difficulty, like trouble with stairs and persistent falls. She began treatment with nusinersen when she was 3 years of age. Her Sandra's status is she has not lost motor function. She does not need respiratory nutritional support. Her self-care dressing pattern is typical for a 6-year-old. She's able to participate in physical activity that is supervised by a physical therapist. This is a typical case of a patient with spinal muscular atrophy type 3. Patient presented with symptoms older than 18 months of age. The maximum motor milestones is walking, and their life expectancy is normal. Patients can walk, as I mentioned, they can reach all milestones, but very often will lose the ability to walk over time. The predictive number of SMN2 copies is between 3 to 4. Immediate treatment is recommended for infants with 4 copies of the SMN2 gene who are diagnosed with spinal muscular atrophy via newborn screening. The indication for treatment in this patient can be explained by the study CHERISH. This was a phase 3 study of nusinersen versus sham control in later onset spinal muscular atrophy. There were 126 patients with homozygous deletion or mutation in the SMN1 gene who had symptoms at age more than 6 months of age. The patients were between 2 to 12 years of age when they were screened, and they were able to sit but never had the ability to walk independently. As we see, we have 2 scales here. The first one is the Hammersmith motor scale that shows in the gray line the patients that were on the sham group. As you see, with time, the patient is able to reach some of those milestones, but then with time, the patient will lose functionality. In the blue line, you see the patients that are treated with nusinersen as how they can do not lose, but they can actually progress, getting more milestones and getting more motor function. In the other scale, we're seeing the upper limb module, and this is only to evaluate upper extremities. Again, the gray line is the patients that were not treated, and the blue line are the patients that were treated with nusinersen. Patients like Sandra still have a risk of developing some orthopedic complications. Spine deformity, even though it's not common, can happen and may require surgical intervention. Chest deformity, again, not as common, but it's also important to look into it because some patients that are ambulant and lose ambulation will behave more like a sitter and can have these kind of complications. Hip instability, contractures, very important. Contractures can happen in their feet, can happen in their knees and hip. So it's important to manage them because not only can impair function, but it can also can cause pain. Fractures are also another risk. Patients, because of their ambulatory status, can suffer falls and have fractures affecting the lower extremity long bones. For patients like Sandra, one of the most important resources should be directed to accommodations to improve their functional status. These patients are very often going to school and they need to have special resources and accommodations that can help them going through the day. Within those, the use of elevators, the use of mobility equipment, and extra set of books, for example. Another point that is important is the use of other mobility equipment. Sometimes, even though they're ambulatory, they may fatigue, they may have many falls even after treatment. So having wheelchairs that can support long distances, it's very important in this case.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/HWV860. This activity is supported by an educational grant from Biogen. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.